לעשות או
אוקיי. טוב, אז בואו נתחיל. לאט לאט אנשים יצטרפו. ערב טוב, טוב לראותכם בערב זה. אני באמת ככה מתרגשת להיות כאן, לראות אתכם בקהל. חלקכם פנים מוכרות, כולל מרצים, מדריכים, כולל הגרה כאן, וקולגות, אפילו ככה מודרכים מודרכות, אז שמחה לראותכם הערב. למי שזה נוח, מוזמנים ככה לפתוח מצלמות, לפחות בהתחלה, שנוכל לראות זה את זה, זה יהיה נחמד. ואנחנו היום ניכנס להרצאה מאוד מעניינת, שבעצם מתארת את התרומה של גישת סכמתרפיה לתרומה הייחודית בטיפול בטראומה, שזה בעצם מזכיר לנו כאילו היה אפשר לשכוח שהיום הוא היום ה-709 למלחמה. בשבי נמצאים, לא להאמין, עדיין 48 מאחינו ומאחיותינו, והעובדה הבלתי נתפסת הזו מגלמת בתוכה את זה שהנושא סביבו התכנסנו היום היה ועודנו כה רלוונטי לנו, למטופלנו, למדינה שלנו, טראומה אקוטית ואבל מתמשך. אז לפני שנצלול להרצאה עצמה, אגיד כמה מילים בשם אסתי, ארגון סכמתרפיה ישראל. שמי לילך קורן, אני פסיכולוגית קלינית, מטפלת סכמתרפיה מוסמכת, כאן כנציגת דירקטוריון אסתי, שבשיתוף פעולה עם הגרה פלדמן מהמרכז לסכמתרפיה בכפר סבא, ארגן את הערב החשוב הזה. קצת כמה מילים קצרות על אסתי. מדובר בארגון שהוקם בשנת 2019, מתוך שאיפה לייצר בית למטפלי סכמה בישראל. מאז צוות הדירקטוריון מתחלף מדי שנתיים, ובשנתיים האחרונות ככה עשינו מאמץ לפעול בכל מיני יוזמות, בין השאר סכמה בסלון ג'ורנל קלאב שחלקכם שמעתם, שדרגנו באופן משמעותי את האתר, אתם מוזמנים לכתוב בגוגל ארגון סכמתרפיה ישראל ולהתרשם. כרגע יש הרבה מאוד חומרים מקצועיים, הרצאות, מידע על הכשרות, כולל ההרצאה הזאת שתשלח לכם בהמשך. השקנו כרטיס חבר חדש למטפלים מוסמכים ומוסמכות בסכמתרפיה, שכולל גם הטבות והנחות, וכמובן הכנס השנתי במרץ, שחלקכם נכחו בו. ובעצם הכהונה של הדירקטוריון הנוכחי מגיעה לסיומה עוד חודשיים בלבד, כך שזאת ההזדמנות שלכם, מי מכם שהוא מטפל או מטפלת מוסמכים בסכמתרפיה, להציע את המועמדות שלכם לתפקיד. מעבר לכך שזאת ככה הזדמנות לכנות את עצמכם חברי דירקטוריון, לא משהו שאנשי טיפול יכולים לעשות בדרך כלל, להרשים ככה קצת את הסביבה, זאת גם הזדמנות לקחת חלק פעיל בעיצוב הקהילה שלנו, חוויה אישית ומקצועית שמעניקה המון בחזרה מניסיון. אז במידה וזה דבר שיכול לעניין אתכם, אתם בשמחה מוזמנים לכתוב לנו למייל, לכתוב לי בפרטי, אנחנו נשמח לכוח חדש ורענן. אז לפני שנתחיל, כמה עניינים טכניים. ההרצאה היום תועבר בשפה
חשוב.
האנגלית. רק תשמרו על עצמכם במיוט, תודה. ההרצאה היום תועבר בשפה האנגלית. במידה ואתם רוצים, ניתן להפעיל מעין תרגום סימולטני. אתם עושים את זה, תכף אני אכתוב את הכל בצ'אט, הכל יהיה כתוב, אל דאגה. אבל אתם יכולים לעשות את זה על ידי לחיצה על כפתור ה-Captions. אם הוא לא מופיע לכם למטה, יש כפתור של More או עוד 3 נקודות, ואז אפשר ללחוץ על Captions או כתוביות. שם אתם יכולים ללחוץ Show Captions או הצגת כתוביות, ולבחור את שפת הכתוביות שנוחה לכם, אנגלית או עברית או כל שפה שבא לכם עליה, ואז הכתוביות יופיעו באופן אוטומטי בתחתית המסך. אם הכתוביות מפריעות, פשוט תלחצו שוב על Show Captions וזה ייעלם לכם מהעין. אם יש שאלות טכניות לגבי עניין התרגום, בבקשה אל תכתבו את זה בצ'אט הכללי, תכתבו את זה אליי ישירות בצ'אט, כדי שזה לא יקפוץ לפטרישה ויפריע לה במהלך ההרצאה, כל מיני עניינים טכניים. אני פה לצרכים טכניים. אם יש שאלות, הגרה ככה תעקוב בצ'אט, תאסוף את השאלות המרכזיות ונשתדל לשמור לזה זמן בסוף ההרצאה. אז אם יש לכם שאלה, בבקשה לכתוב בצ'אט, לא לצאת ממיוט ולהגיד, כי זה עלול להפריע לפטרישה במהלך ההרצאה. והקלטה של ההרצאה בנדיבותה הרבה של פטרישה תשלח לכל הנרשמים והנרשמות היום, כולל מסמך מקיף שהיא הכינה בנושא, כך שאם יהיו לכם שאלות, דברים שאתם מרגישים שפספסתם, הכל יהיה כתוב בצורה מאוד מפורטת ומסודרת. ההקלטה הזאת תגיע אליכם במייל, ולמי שזה מסתבך, אז אתם כמובן מוזמנים לכתוב לנו צוות אסתי. אז אני מקווה שהסברתי את כל העניינים הטכניים. אני ככה רוצה להגיד המון המון תודה, שוב, גם לפטרישיה שככה הגיעה כאן בהתנדבות מלאה, ככה ידידת ישראל, מאוד, דבר שהוא לצערנו מאוד מאוד נדיר. אני רוצה להעביר את השרביט להגרה פלדמן, שככה ארגנה, יזמה את האירוע החשוב הזה. הגרה היא מדריכה וטריינרית ב-ISST ומדריכה מוכרת באיטה, מלמדת ומכשירה בסכמתרפיה ומייסדת תוכנית ההכשרה המרכז לסכמתרפיה בכפר סבא. בעבר, אגב דירקטוריון, חברת הדירקטוריון הראשון של אסתי, יושבת ראש הוועדה למדינות מתפתחות ב-ISST, וכיום חברה בקבוצת העבודה העוסקת באתיקה ב-ISST. הגרה, אלייך, תודה.
תודה רבה לילך. וואו, כן, ערב מרגש ממש, ואיזה נוכחות, חבל על הזמן. קודם כל באמת לילך, אסתי, תודה לכם שככה ישר הושטתם ידיים תומכות ומחזיקות להרמה של האירוע הזה, אני לא יודעת אם זה היה קורה בלי זה. וערב טוב לכולם, תודה רבה רבה שהצטרפתם אלינו. כמו לילך, אני גם רואה פה חלק פנים מוכרות וחלק חדשות, אני שמחה לראות את כולם, והי. אני ככה אומר רק בכללי, אני אעשה את זה מאוד מאוד קצר, כי לפטרישיה יש כל כך הרבה מה לתת לנו, והזמן שלנו מאוד קצוב. כל מי שעובד עם סכמתרפיה, אני מניחה שיודע עד כמה היא מדויקת ועוצמתית בטיפול בטראומות התקשרותיות. זה משהו שאנחנו יודעים לעשות אותו טוב, אבל אני מניחה שלא מעט מכם שאלו את עצמם, אוקיי, מה בעצם יש לסכמתרפיה להציע כשמדובר בטראומה אקוטית, זה כבר אזור קצת אחר. אז בדיוק לשם כך התכנסנו היום, כדי ללמוד מדוקטור פטרישיה אסקודרו רוטמן, שהיא מומחית הטראומה ממש של ה-ISST, שהיא תעזור לנו לחבר את הדברים ולעשות ככה שימוש בכלים ובשפה שמוכרים לנו מסכמתרפיה, לתוך טיפול בטראומות אקוטיות. אני באמת שמחה ונרגשת, ואנחנו רוקמות את המפגש הזה כבר ככה זמן מה. פטרישיה היא חברה יקרה והיא קולגה מוערכת, והיא באמת, כמו שלילך אמרה, ככה ליבה עם ישראל, ובנדיבותה הציעה לנו במתנה את הוובינר הזה. כמה מילים עליה, שוב בקצרה. אז דוקטור פטרישיה אסקודרו רוטמן היא פסיכולוגית יהודייה, ואני אומרת יהודייה כי זה ממש היה לבקשתה לציין את זה, מארגנטינה, אשר הוכשרה ועבדה גם בארגנטינה וגם בארצות הברית. היא חיה בארצות הברית 23 שנים, ושם היא עשתה בעצם את ההכשרה שלה בסכמתרפיה אצל ג'פרי יאנג בעצמו, וגם הייתה חברה במכון שלו בניו יורק. היא גם עוזרת פרופסור במחלקה לפסיכיאטריה בבית הספר לרפואה מאונט סיני בניו יורק, ולמעשה חלק מהידע שלה ומהניסיון שלה בתחום הטראומה כולל עבודה אישית שלה עם נפגעי אסון התאומים. זה היה באותה תקופה, ועם כל הצוותים המסייעים, אז הם גם ראו כמה דברים. זהו. טוב, אני לא אוסיף, תוכלו לקרוא בפירוט אחר כך עם כל שאר החומרים שנשלח לכם בימים הקרובים, גם את הביו היותר רחב שלה, ואני, זהו, מעבירה את זה ככה אליה. שאלות כמובן, כמו שלילך אמרה בצ'אט, אני אאסוף אותן, ובסוף מה שהיא תוכל היא תענה, והיא גם אמרה שמה שלא היא תנסה לענות אחר כך בכתב. אז זהו, פטרישיה, please. Thank you so much for this generous gift, and the stage is yours.
שלום, שלום, ערב טוב, תודה על ההזמנה. If you understood what I just said, you made my week. So, thank you very much. Thank you very much to the organizers. Thank you very much to my dear Hagara. And okay, so what I will share today, I hope that some of what I share will be helpful to you. You're going through a very difficult, very challenging, and very complex situation. And really, I hope that you can adapt some of the things I share to your patients and to your context. So without further ado, I will share my screen, hoping that everything technologically wise goes well. Okay, so far so good. You can see my screen, right?
Yes, we can see it. Yeah.
Okay. But now it sounds like, okay, yes, good. Okay, so as you know, there's trauma, natural trauma and interpersonal trauma. And I went through several collective traumas. I was part of a triage center in the world disaster. And it was an interesting experience. And back then and there, we realized that the Mitchell model, as I will mention later on, was not a good intervention. And that was the Mitchell model. That was the model where we probed for feelings, among other things. It was a single session. But anyway, we'll talk about this. So by the way, I will skim through the slides so I have time to share with you 2 videos of 2 sessions that I think will be interesting for you. So the question is, should we obey the DSM-5 TR? And the reply is no, because what we schema therapists know is that what count is individual subjective experience, such as, for instance, being the victim of infidelity could be traumatic for some people, not be so traumatic for others. And so keep in mind that what is important is the experience. Like, for instance, here we have acute trauma that threatens the emotional integrity of a person. The image here shows a woman who I saw, excuse me, a woman who I saw many years ago. She had a panic disorder. I did the protocol, David Barlow's intervention with interoceptive exposure, etc. But afterwards, she unfortunately presented with OCD aggressive type, which is the worst type of OCD, as you may know, or one of the worst. And she felt that she wanted to kill her 2-year-old baby to death. Fortunately, I did some psychoeducation, and she decided to hospitalize herself. And fortunately, the psychiatrist who saw her knew a lot about OCD, so he reassured her that she was safe. She reassured, of course, her husband. So financial safety, you know, the image there shows what happened in Argentina, which was that the banks took the money from, all of a sudden, took the money from people, you know, from clients, and that was a major collective disaster. Many people committed suicide, elderly population especially. So these are some screening tools that you can use. Brian's acute trauma scale, Beck depression. Many of the people who go through acute trauma, they are very depressed and may even attempt or commit suicide. Young and Rick avoidance inventory. I had the privilege of being in the center, Jeffrey Young Center, with Jane Rigg. And but this questionnaire is included in the SMI that we all know. The audit alcohol screening tool. We can talk about substance abuse problems. That's also interesting to identify alcohol problems. And the self-compassion scales, it's going to be interesting. This is Kristin Neff's scale. It's going to be interesting to identify punitive critics. And so here we have the typical reactions after an acute trauma. We have a baseline, a group that doesn't present initial symptoms, and it's not likely to present symptoms down the road. But now we have the different group, another group that has doesn't have initial symptoms and has symptoms down the road. It could be even be years later. And then we have the group that presents symptoms, acute symptoms in the beginning, but then those symptoms subside. And then we have the group that's more likely to come to therapy, that has initial symptoms and the symptoms continue. One important piece of information to remember is that most people who go through acute trauma will recover on their own without professional help. And that's important to identify. Some people prefer to talk about acute reactions, normal reactions vis-a-vis an abnormal event. But for simplicity, I will talk about patients here. So it's going to make it simple. So most people will not reach out, okay? So we don't have to expect that we will have many individuals coming for help. And if they do, they may do a touch and go visit. What do I mean? Example, some women attempted suicide when I began to work. I was 24 and I was already a psychologist. So I worked for a general hospital. So some women would attempt suicide. They would come, they would be hospitalized sometimes, and then they will leave the hospital. And even if we had a pretty good ambulatory service, we never saw them again. And this is, of course, related to the avoidant protector related to the trauma. So the idea would be not to push people to come to therapy and consider a screen and treat approach. What do I mean with that? That a universal approach would not be the way to go. So we have to respect people's defenses and again, not to push to come to therapy. So what are the goals of early intervention? Is it to prevent PTSD or to decrease the future severity of traumatic symptoms? Some studies claim and show that some treatment models can prevent PTSD. But as you know, we have acute stress disorder, and after 1 month, the DSM-5 TR will diagnose PTSD. So I believe that we have to be more realistic and think about decreasing the future severity of traumatic symptoms, decrease the suffering. And I take this out of psychological first aid, that even if it doesn't have much research backup, it makes a lot of sense and it has shown to work, to be quite effective. So, but I identify psychological first aid as part of our schema therapy approach, our limited reparenting, because the question here is, what do you need right now? That would be the key question with somebody who goes through acute trauma. So we're going to give priority to safety, physical and emotional stability needs, medical assistance, food, shelter, objects, resources, and help them to make necessary urgent decisions. The idea would be, and this is traditional schema therapy, unless they need to make an urgent decision, let's postpone, okay, the decision for later on. So example, some people who came, they came in a cruise during the pandemic, and they were taken to hotels to quarantine. And some of the people who were in that boat, or at least a few, they had very practical needs to have like a charger for their cell phones to connect with their beloved ones. One had the need for adhesive for his denture. So very, very practical needs. We're not case managers, but this is part of limited reparenting. So we are going to do a needs assessment. And again, sometimes, very often, we have to be very flexible, very creative, and listen very carefully to what the person is saying. Many times, in my experience, often, we do not have the luxury of even taking screening questionnaires. The intervention has to be fast. So a very trained schema therapist, I believe, is the one who can do a better job with an early intervention. So decrease the emotional and physical suffering, heal the emotional side. I prefer to talk about emotional side and not little child, little Hannah, little you. I think it's would induce too much, would induce some regression. So I recommend to strengthen the person's healthy adult mode as much as possible. So vent the angry child mode. This is a very interesting topic for me because I know there's a controversy about how do we help the person to vent the angry child mode, okay? This is not traditional schema therapy. However, there are different ways to vent, and we will talk about that later on in order to, of course, help the person's angry child mode to vent in a way that doesn't put him or her in jeopardy. Identify and respect coping modes. We'll talk about this. There are coping modes that we, in schema therapy, we tend to see them as maladaptive, but during the acutely period, they can be adaptive, right? Like a detached protector mode can be adapted at times, okay? The problem is that if the avoidant protector shows up on a steady basis for a long time, and that, of course, can be related to a pathology. So address and diminish the power of the different critics. This is a key intervention. And that's something that we can identify, we schema therapists can identify from the get-go. So in the sense that we can think about guilt instigating critics, we can talk about punitive critics. Okay, so guilt instigating critic could be somebody whose adult child has not come back from the war, and the mother could say something like, you know, I don't feel comfortable enjoying a meal because I keep on thinking about my son. I don't know if he's eating, he's not eating. So we have to be careful and identify these guilt instigating critics. And strengthen the healthy adult mode, of course, to foster resilience. There are different ways to foster resilience, and that could be a change of posture, that could be doing image rescripting. And when we talk about image rescripting, we can think about it like a bottom-up intervention. Why? Because healing the emotional side of the person can lead to having a healthy adult mode that's stronger. And then, of course, we have all the interventions that come from DBT, which would be more a top-down approach, a symptom approach, and that can also be helpful. And of course, we know that the beauty of schema therapy is to be an integrative model and to borrow different interventions from different models, psychotherapy models. Now it's stuck. Let's see. Okay, so needs. It's important to identify needs. The need for safety, of course. As somebody who has just been robbed, whose house has just been robbed, is terrified that the house is robbed again. Okay, and unfortunately, these things happen in the province of Buenos Aires, and then this can lead to complicated family dynamics because one person, many times, unfortunately, husbands, they invalidate the person's need for safety. And of course, we schema therapists need to give priority to that need and offer practical advice if it's needed, like alarm systems, or of course, do provide emotional validation. Acceptance of what they feel is defective. They may feel like being fearful. That's also very important, especially if we have very demanding modes that get in the way of the person feeling nurtured or feeling understood, of feeling accepted, as I said. Autonomy, competence, identity, those are very important needs. I can think of a patient who was confined in her house during the pandemic, and we did some image rescripting where she could create a scene where her need for autonomy was met, and she could drive around and go to different neighborhoods and meet her mother, etc. Competence. I recall a patient, she was a borderline patient who was feeling very incompetent before the Russian invasion to Ukraine. And however, soon after the invasion, she began to feel very competent, very helpful, because she began to work in a soup kitchen and feed people who had to flee their houses. The need for identity, well, as you know, that's very important. And we saw this need and met with many people who went through the dictatorship in Argentina. Freedom to express needs, opinions, and emotions, that's a very important need. The freedom of people, Ukrainians who were in Zaporizhia to express their opinions. They did not want to be Russians, to adopt the Russian passport or to speak in Russian. And unfortunately, they had, and that was compliance, surrender, that was very adapted at that point to play the game and to do whatever the Russians wanted them to do. So for time's sake, I will skip the other ones. These are the new needs. Some of us are very traditionalist, and we think that they can be included, or they are part already of our traditional model. So psychoeducation is very important because acutely traumatized individuals vary, okay, from mode to mode, sometimes very fast. So sometimes they think they're going crazy because they go from a vulnerable child mode to angry mode, or to a self-soother coping mode, or from a hypersexual mode to being detached, which is, as I said, sometimes is very adaptive, such as somebody who's being wheeled into an operated room and the person detaches and thinks about safe space, etc. And that mode can be very adaptive. And of course, we have the resilient coping mode that can take focus on what they are given, what they receive from other people, and use resources as well, practical resources, and cope as much as possible with very adverse situations such as war or trauma. These are some of the modes. Again, I'm skimming through because you're schema therapists and you know all these different modes. And then we can use strategies from schema therapy, such as limited reparenting, identifying the need. This is much easier to do with existing patients than with new people, persons who come to us, okay, in the middle of this crisis. Because with existing patients, I'll give you an example. Let's call her Marika. And she had a severe avoidant personality disorder. So her need for empathy was the main need. And I was trying to meet this need in the therapeutic relationship. But when her parents had an almost fatal accident, she needed practical advice. She needed advice and assertiveness role plays where she could practice how to talk with the surgeon, who was very nasty, very intimidating. And we practiced, what she wanted to say. So that need superseded the need for empathy at that point. Cognitive strategies can be used, but this idea of what's the evidence that confirms or disconfirms schemas, or thoughts, etc., this would be experienced as very cold. And experiential strategies. I have used a lot of image rescripting. Some of us know that I even advocate for helping the person to express anger with image rescripting. And I know there's a big controversy in schema therapy about this, revenge fantasies, but I do believe that this could be a part, of expressing anger. Of course, the ideal scenario would be that the person gets stabilized, okay, and for that we can use different models. We'll talk about the assist model, okay, which comes from the EMDR and has been developed by Ignacio Jarero. And that helps with stabilization. But sometimes the anger, schema therapists, we need to listen to the anger and help, with the top-down approaches, like, example, one of my patients whose husband had abandoned her and raped her during the last relationship, sexual relationship, she was furious, and she created what she called the rage walk, which was she was walking around Central Park listening to heavy metal music, and that helped her. Now, we did also image rescripting, okay, that was very healing for her, where she had this husband who would do martial arts and almost stab her and cut her, with the knives that were coming very close to her body. And she did wonderful image of rescripting where she would be more powerful and to have these swords melt in front of her. And many, many interesting, I can have many, many interesting examples. Now, it's important to adapt image rescripting, okay? And I will just say it, So I was planning to say it later on, but the idea would be to co-create the script with the patient and only do image rescripting if the other techniques do not work and if the patient wants to do it. But co-creating gives the acutely traumatized individual a sense of power, a sense of self-efficacy, and feeling, as I said, empowered. So I would not do image rescripting of childhood images, and I would try to stick to the trauma and do a lot of debriefing, grounding at the end, a cognitive work of seeing what helped, okay, and emphasizing on that, and emphasizing on resources of her healthy adult mode that will be needed, not because of the imagery that could be stabilizing. And something that I spoke with my dear friend Remco, who's the expert in imagery, and I think it could be stabilizing. Okay, behavioral strategies, as I said before, can be a way to go. And this is Marilyn's crisis intervention conceptualization, graphic conceptualization. Marilyn was somebody I worked with whose husband had committed suicide 3 days before I met her. Again, these are many times not traditional situations where we have the patient who comes to our office. This is somebody who's screaming, and in the street, in the neighborhood where I was working. And I approached her to see if she wanted some help. And I worked with her for 5 sessions, and it was very healing, okay? Okay, so this was during the pandemic. The law at that point was not to open any stores, as you may remember. And she broke the law at some time because she opened her store. And she was overly independent at some point. She did not want any help. Avoidant coping modes were associated to blocking her feelings of despair and hopelessness at times, and avoid opening her late husband's farewell letter, which I thought was very functional at that point. Compliance surrender coping mode, feeling guilty of having killed her husband, feeling that she deserved punishment. Vulnerable child mode, feeling sometimes very abandoned, overwhelmed, desperate, hopeless, and even relieved sometimes. That's something that I would like to make a reference of, because some acutely traumatized patients, and of course people who have PTSD, feel ashamed of feeling relieved sometimes. And we need to anticipate and probe for, even if we don't have to probe for feelings very much, this is not the Mitchell model, But sometimes we have to listen for feelings that people are ashamed of saying. And she was feeling relieved because her husband had been abusive with her and with her children. Angry child mode, feels angry with late husband for having abandoned her and demanding punitive critic, guilt instigating voices that says something like, you should have realized he would attempt suicide, when actually these men had been seen by psychiatrists and psychologists who did not pick up the risk. And the healthy adult mode, fortunately, accepted that her store would be temporarily closed due to the quarantine and continued helping her kids with their homework and everyday needs, okay? Routine, by the way, helps a lot, even if it's basic routine. Somebody is depressed, is going through a severe depressive episode, just some advice of having her clothes at night ready, because usually people feel more depressed in the morning. Have some coffee and something very delicious, waiting for them in the morning. So have some music so they can click on Spotify and listen to some music, something that helps them to regain stability, one of the major emotional needs. And she feels uncomfortable, but did accept her sisters and her aunt's help. So the question here is, to share or not to share? Should we encourage persons to share or not? But patients sometimes will overshare. And of course, there's a risk of destabilization and re-traumatization. And sometimes they will undershare. And of course, the risk is not meeting the emotional side's needs. Now, psychologists, we tend to think sometimes that the person who shares his or her feelings is on the healthier side of the spectrum. I don't think that's the case, because somebody can avoid, and that can be an adaptive coping mode, and be as healthy as somebody if down the road he can begin slowly, to open up. We will talk about this. So I would like to share the video recording so you see what I mean with that. So let's go to the video recording of an incorrect session, okay? And this is my dear friend Marcia Blank, with whom I worked in the Schema Therapy Institute, Jeffrey Young's Institute. So in the first scene, you will watch a well-intentioned therapist who has a first session with a patient who went through a traumatic situation a few days before. The clinical interventions used by the therapist are the ones many, or at least some therapists, are likely to use, not you, of course. Unfortunately, this type of early intervention is not helpful and is likely to lead to re-traumatization and then to dissociation. Therefore, this well-intentioned therapist will hurt the patient as she will go out of the window of tolerance. Hello, Paula. Very nice to meet you. Your friend told me that you went through a horrible situation, and she also said that you should seek help. And she also mentioned that you have never been to therapy. Is this right?
Yes.
Okay, Paula. Tell me all what happened to you. I need to know everything that happened to you. If not, I would not be able to help you.
Patricia, can you pause for a moment?
Sure.
Yeah. Okay, just to make sure that everyone is aligned with what's going on, this is an example of a bad intervention, okay? זו דוגמה להתערבות לא טובה. Okay. Thanks, Patricia.
Thank you. Yeah, if you want to say it in Hebrew.
Sure.
I'm a waitress at a very famous coffee shop. That's where that man entered, the man who was stabbed to death last week.
Go on, Mary. What happened? Tell me everything that happened. Try to include all the details. It's good that you get it all out.
He entered the cafe. He was stumbling. I approached him and was ready to kick him out. I thought he was drunk. But, you know, I have orders to kick out beggars. So, you know, and I've always felt bad about kicking these people out. I just want to get something to eat.
Okay, Paula. So let's go back to the scene. So tell me, Paula, what happens next? Please speak as if the scene is happening right now. Look at the man. Where is he now?
It's so horrible. He fell on the floor. And you know, I realized he was bleeding and there was a pool of blood. And it was getting larger and larger. Like, I was in shock. Like, everything seemed like it was happening in slow motion. You know, I just didn't know what to do. I really don't remember what happened next. I feel so bad, but I really don't remember.
Okay, Paula, try to remember. It's important that you remember everything that happened. And please speak as if the scene was happening right now.
Listen, I don't remember anything. That's it. I just don't remember.
For time's sake, I will.
Okay, Paula, look at.
I keep telling them everything that happened. I mean, I know they have the right to know. They're trying to help. I'm a witness, so I need to answer all their questions, but then I have nightmares. I'm having nightmares. I keep seeing that man lying on the floor in this huge pool of blood. And I hear him saying, I don't want to die. I don't want to die. I just had a baby. He needs me. I can't die. I felt, you know, I was paralyzed. I just wish I could have helped him. But I was paralyzed. I felt so impotent. I just felt so helpless. I couldn't move. I just couldn't move. I couldn't save him. These images and feelings are they going to stay with me?
Again? When you were 8 or 9 years old, let the image come. Do not force it.
I'm doing
and when the image comes, let me know what you see.
Of course.
I want to connect with little Mary. I want to
idea.
connect with your little girl who's suffering
Even
so
if it's
much.
connected.
Little Paul.
Paula, can you tell me what scene came to mind? Paula, can you hear me? Paula, can you hear me? Paula, come back.
That was so horrible. That was terrible. That was awful. I listen. I want to go home. I really have to get out of here. I have to go. I've got to go home. Listen. I've got to leave. I don't want to come back here.
No.
I
No,
don't
no.
want to be back here.
No,
You
no,
know,
no.
this therapy wasn't going to help me. You know, I was right. I was right. This is making me feel so bad. I'm leaving. I've got to go.
No, no, no. Paula, no, don't leave, Paula. You know, don't leave. You're not feeling well. You cannot leave now. Let's talk about what happened. Okay. So, needless to say, this is what we should avoid. So, it's important to avoid showing up in a robotic, cold way, matter-of-fact way. By the way, are you there? Because I don't see my slide only.
Yes, Patricia, we're all here.
Good.
We can see you.
Okay,
Maybe I hope it's okay to ask, maybe if you can speak a little bit slower, because also the translation doesn't work for some reason. So maybe, yeah, is that okay?
Yes, yes, absolutely, absolutely. Anyway,
Thank
I
you.
think it's important to read it, okay? And all what's there is what you already know, which is to identify main unmet core needs, avoid probing into feelings, validate patients' feelings. For time's sake, I will skip fast. It's important to normalize reactions, avoid insisting on a chronological narrative. This is important because I know that maybe some of you are using narrative exposure therapy where the traumatic event needs to, at some point, be integrated in the autobiography. But at this point, if we insist on a chronological narrative, this could activate the effectiveness shame schemas. It's important to avoid forcing patients to fill self-report questionnaires. I'm talking about the schema therapy questionnaires, and because they could be, of course, too activating, triggering, and avoid telling patients what to do. It's important not to make empty promises, like I will be here for you 24/7. It's impossible. So to identify resources and to be honest, like we schema therapists are, is important. It's important not to force your personal values. This applies, for instance, to my Hispanic, Spanish-speaking therapist, in Latin America, who sometimes do not feel comfortable with finishing pregnancies, and sometimes without noticing, they force their personal values on patients who want to finish or who are considering to finish pregnancies. Question coping modes that are maladapted and maybe temporarily adapted, that's important. And to forget, it's important not to forget to confront coping modes that are maladapted. I'm talking about substance abuse that can have consequences, and the person can end up behaving, acting in a way that's contrary to their values, like family values, for instance. So let's go now to the corrective version, okay? I don't want you to think, and end up with that version. Okay, so let's go now to the corrected version, to the corrected simulated session. The therapist went through an intensive training in the recommended schema therapy strategies with acutely traumatized patients. The content of this scene is going to be a little bit different than the prior scene because the clinical interventions lead to a different outcome. Let's see how this scene goes. Hi, Paula. Very nice to meet you. Your friend told me that you went through a very traumatic situation. She also said that you have never been to therapy. Is this right?
Yes.
So, Paula, you seem to feel a little uncomfortable about being here. Is this so?
Yes, I guess so. My friend was worried because I saw the man who was stabbed to death in the park. I was working as a waitress in that coffee place, and he came into the cafe. I almost kicked him out because the cafe, they don't allow beggars to come into the place, and he was stumbling and then he fell down, and it was a pool of blood. Oh boy.
Okay, so Paula, let's stop here. No need to tell me more. What happened was horrible, and I know enough to understand. Anybody who witnesses something so horrible would feel terrible. It's totally normal to feel this way.
But, I want to tell you because I was told that I need to talk about everything that happened and that I have to express all my emotions. Why don't you want me to tell you everything that happened?
Okay, Paula, I am very interested in knowing everything you want to tell me. And I realize that maybe there's a part of you that feels upset when I tell you that there's no need to tell me everything now. But I'm concerned that you may feel worse after you tell me. Your sister also told me that you have been having problems to sleep. Let's go back to the present. Paula, how can I help you now?
I really don't know. But I feel so guilty. I almost kicked this man out. And really, I did nothing to help him. I just stood there watching. And fortunately, there were people who tried to stop the bleeding. I was completely paralyzed. I just keep having images of the blood, that the blood was leaving him so fast. And hearing, and I keep hearing what he said. He kept saying, I don't want to die. I don't want to die. I just had a baby. He needs me. I can't die.
Okay. Paula, look at me. It's really horrible what you went through. Let's stand up and stretch. Please tilt your screen so we can see each other. Okay, good, excellent. So now, let's open and close our hands. Close and open. Close and open. Great. Do it at your own pace, at your own rhythm.
Oh,
great. You're doing great. And now let's hug ourselves. Let us feel how our hands caress our arms. And while we do this, let's breathe in and let's breathe out. Breathe in and let's breathe out. Paula, can you feel your hands caressing your arms? Good. And now let's press our arms a little so we can feel like we're containing our emotional part. This emotional part that's going through a very difficult time. Can you feel your hands putting a little pressure on your arms?
Yeah, it feels good.
Okay. How does it feel?
It does.
Great. Okay, so Paula, let's sit down again. And let's talk about what's going on. But if you feel the need, we can always stop talking about this. We're talking about a very difficult situation. So it is totally okay to stop. You are in the driver's seat. And please raise your hand if you want to stop talking. Can you raise your hand so I know you will remember to do this if your emotional side needs it? Great, great. We can also stand up and stretch again as we did before, okay?
I think I feel more calm.
Okay, great, great.
Oh, good.
Good. Paula, what's happening to you now is very normal. There's a part of you that we can call the critical part that is making you feel bad. And this part is saying that you should have done something to help this man. But it is a normal and frequent reaction to feel paralyzed. You were in shock. We could call this part the traumatized part. There was nothing you could do. Some customers called 911, and that was all what could be done.
I hear you, but I just feel like I don't think this guilt is going to go away. And not only that, but I just keep having the images of the pool of blood and hearing this man's plea, of saying, I don't want to die. I just had a baby. I won't be able, I just feel like I won't be able to forget what happened.
Of course. I totally understand that you do not feel that your guilt will go away and that you think that you will keep having these images and hearing his voice. Paula, I cannot promise you will forget this situation, but I will help you to overcome these difficult feelings and images. I know that you will feel better. I know that you will be able to move on with your life. I know you will be able to have an enjoyable life. I can help you.
Okay, but I'm not really sure that you can help me. You don't know this about me, but I had a horrible childhood. My father was physically abusive, and I don't know, maybe I should talk about this.
Okay, Paula, no need to talk now about what happened in your childhood. And it's totally okay. If you're not sure, I can help you. Actually, I totally understand that it is very difficult for you, for anybody, to feel safe and trust that you will be fine. Totally normal, totally understandable, one step at a time. Is there anything else you want me to help you with? Okay. So just reviewing, it's important not to focus on traumatic situations that happened in the past, ideally, okay? I know some models would advocate for this, but we have enough with this traumatic situation just to begin with. Do imagery rescripting is a no-no. Forget to instill hope. It's not a good idea, of course. And it's important not to avoid addressing and confronting critics. It's recommended to strengthen resilient patients' healthy adult mode. And for that, if I had the time, I will show you how in image rescripting and mode dialogues using chair work, I will always finish a session with the person, knowing that sometimes could be the only and last session or meeting, and strengthening the healthy adult mode that can confront the critics, the guilt, the different critics, okay? And not only be the ones be the one who confronts the critic and comforts the emotional side. The healthy adult mode needs to be activated and strengthened and do the work. So it's important to remind patients about existing coping skills. And when I talk about existing coping skills, I think it's important to identify what has helped the person before, okay? So the idea is not to come up or to create new coping skills, okay? Just very brief example. During the pandemic, I remember that very well-intentioned psychologists specialized in mindfulness were trying to help patients to do meditation, okay? And when I talk about patients, they were trying to help physicians. The physicians did not have time to breathe. So what I was suggesting was to do mindfulness of activities, right? Like going to brush their teeth, grab the toothbrush and feel the pressure of the toothbrush on their teeth, or savor, feel the flavor of the toothpaste, and being mindful of every little thing they had to do. That we have to be realistic. I think that's important, very, very important. So tell them about available resources. Yes, support groups. Sometimes they don't go, as you know. And sometimes they go, they identify the differences and not identify the commonalities. So their schema isolation schema can show up, and they don't feel they belong to this group and leave. So include a healthy adult mode practice, anticipate future stressors and how to cope. That's also important. We can do this with imagery. Okay. And some affect regulation techniques. I'm sure you know them. The Linehan, mindfulness of activity, centering technique. This is Levine's intervention. I use this, quite a lot with some borderline patients. And by the way, there are many similarities between working with crisis with borderline patients than working with acutely traumatized individuals. Self-hug technique, just squeezing, that can be also to counteract dissociation, okay? The butterfly technique, okay. I trained in Artigas and Jarero's protocol, and so the butterfly technique can be good to stabilize the person, okay? This is not processing, the pathogenic memories, but this is for physiological stabilization, and that can be very good, of course, with somebody who's acutely traumatized, okay? For processing, okay, I prefer to use imagery rescripting. Escape to Paradise, that was something about videos that I came up with, beautiful videos of landscapes drawn over flying Norway, Norwegian fjords, and to counteract the feeling of confinement, of cabin fever that many people had. Many of my patients had during the pandemic. I had them, I used them, and they were helpful. Audio flashcards and video flashcards. Excuse me, this could be very good, very important, something like very brief, like I know you're going through a very difficult situation. I know you feel very alone. I know you feel you are in a black hole and you will never be able to have a good life again. But I know, you have coped with the adversities before, and you overcame very difficult situations before. And I'm here for you if you need me. Hang in there, one step at a time. Things will get better. So, imagery rescripting, the question here, as I said, is it the stabilizing or is it the destabilizing intervention? And I think it can be well tolerated many times. I think it's important to be attuned with your patient and to remember that many studies have shown it can help patients with adult trauma, complex trauma, PTSD, and social anxiety. And clinical experience, my own and my supervisee's clinical experience have shown that it can also help individuals with acute trauma, is, as I said, adapted to. to this population. Research is needed. So it can provide an emotionally corrective experience. It can be like going back to that time where a friend, a close friend, or a stranger brought some food, okay, delicious food to them. And that imagine, going back to that imagery, can be a very healing experience. And the imagery scripting is important. As you know, there are different hypotheses about the mechanism of change, but one of them is that patients are able to express what they were not able to say or do during the traumatic situation because of survival needs, of course, okay? But this time they can do whatever they need to do, they would have liked to do. And the question here is, are they going to confuse reality with fantasy? And if we prepare them, you know, when we do psychoeducation first and we let them know that this is an image and this is fantasy, but it's going to be healing for them to be able to even kill the person. If there's no history of violence, you know, even kill a rapist in imagery, according to Arndt's studies, I think that it could be very healing as well. Okay, then debriefing, grounding, cognitive work to see and having to see the message of how they feel, of course, and we can always rewind the image if the image feels like it was too much, too intense. You know, the person can do another imagery that's more appropriate to what they prefer, what they feel comfortable. At least that was my experience with a patient who was a Buddhist, okay? And she preferred to change the scene, the initial scene that was, she felt it was a way too aggressive. So patients' emotional size needs to get their needs met. And as I said, could be a stabilizing intervention. So this is a patient, I don't have time to show you, who went through an earthquake.
I have to try to.
So the use of mode dialogues using chair work is recommended. I recommend it. Therapies and confronts the, identifies that confronts the critic. So I believe that to work with the critics, it's better to use mode dialogues using chair work. Okay, it's more concrete. The therapist feels more empowered. The healthy adult is more likely to stand up and confront the critic. So it's important that schema therapists who work with these patients are flexible, creative, and accept personal limitations. For instance, in the case of a woman who wanted me to see her sister who had gone through amputation of hands and feet. Honestly, I couldn't do it. I was not in a good situation. And I'm not really sure, honestly, if I can still work with this person. So I referred her to another colleague. So unfortunately, she died, you know, very soon after I got in touch with this woman, with her sister, because I began to talk with her. Self-compassion is important, and to have a support system. These are very difficult clinical situations. And also, I believe it's important to have realistic expectations of the early intervention, accept limitations, find and use your support system, because sometimes we have our support system, but then we have a demanding critic that can say, come on, don't bother, and a guilt-instigating critic that says, don't bother, Kagara, you know, she's having her own situations, her own problems that we all have, of course, you know, don't bother her. So I think it's important to be compassionate and to reach out for help. If the person cannot help us, okay, that's okay. You know, we can go to another person or to use a support group if we have it. And remember, of course, to have our happy child mode activated. So these are some of the summary. the interventions, psychoeducation, brief risk assessment using screening tools, if possible, strengthen and teach affect regulation skills, comfort and provide emotional validation to the person's emotional side, activate the patient's healthy adult mode, diminish punitive and or demanding critics, guilt instigating catastrophic voices as well, and identify and diminish maladaptive coping modes and respect the adaptive ones, do grief work, and anticipate and identify how to cope with future stressors. Okay, this is part of a longer training, 6-hour, day-long training. And if you want to reach out, these are social media. And by the way, you have in our website, in our institute's website, the one underneath, you have many webinars. Okay, you can see some fragments of some webinars, with the international experts, in borderline, John Farrell, Wendy Behari, David Bernstein. And if you want, you can buy the whole webinar, but you have pretty large segments. Okay, so I prefer to leave it now for time reasons. Let me just stop sharing.
Yeah.
Okay.
Oh,
so,
wow. Wow. Thank you so much, Patricia. Just let me tell everyone here, when we'll send you all the materials afterwards, you'll also have Patricia's link to her, is that okay, Patricia? To your website, so you can really, אפשר באמת למצוא שם חומרים מצוינים. פטרישיה מראיינת את כל המובילים של תחום הסכימותרפיה בעולם, ויש שם דברים שווים שכדאי לראות, באמת במחירים קטנים כאלו, $25, משהו כזה, אז שווה. I was just telling them about the things they can find on your website. שאלות, questions?
If there are no questions, Hagara, I would like to know their experience, participants' experience, because I would love some feedback. By the way, I would really love it if you can send me an email and share your own experience of what has been helping. You are experts in trauma, okay? And you're experts in working with Israeli patients, okay, existing patients or new, having new consultations. So I would really like to know, and if you can think about what I shared about the interventions, about image rescripting, doing mode dialogues, using chair work. I would really like, and I would really appreciate, because I want to learn from you. Okay, so please, you will have my email address. And if you can share with us some experiences, that would be great.
אם אתם מתביישים עם האנגלית, אז תגידו בעברית ואני אתרגם. I will translate if someone feels uncomfortable with English. That's okay. If no one wants to ask anything, I just wrote some notes to myself. Oh, sorry.
Okay. Yeah. I'd like to ask a question. I had some experience the last 2 years working with soldiers after combat, and some of them are dealing with very strong feelings of guilt and moral injury. So my experience is that trying to confront the critic at an early stage leaves them feeling very alone, and it's more effective to try and be more validating before confronting, because confrontation will leave them feeling more alone and ununderstand like feeling more that what they went through, only they can understand, and the other person, the therapist, can't understand what they went through. So I try validating first and only much after confronting.
Yeah, thank you. Thank you. I think it's great. And thank you for sharing your experience, because I see that you have tried to do mode work. So I think, yeah, emotional validation, I totally agree, is the key intervention, and is the initial interventions, because they need to feel understood and supported. And we schema therapists are very well trained in being in tune with feelings. And sometimes, though, what I find is that some individuals have what we can call secondary alexithymia. Okay, so what do I mean by that? They do not know what they are feeling, okay, and what they need. So sometimes, or sometimes the critic, even if we do not work with the critic, can say something like, with the patient I was sharing, how can you feel relieved? Okay, so even if we don't work with the critic, tell me what you think about this, we can identify, we can anticipate which that could be a possible feeling, especially if the patient has hinted, okay, that that could be one of the feelings. So to normalize could be that. But yeah, the intervention should focus first in the needs. Okay, it's important to do a needs assessment, and in this situation, with some of your patients, emotional, identifying and meeting emotional needs. Okay, but also I think it's important to realize that they may not feel understood. Okay, maybe we don't understand. Okay, unless we have been through a similar situation, and even if we have been through a similar situation, we may not understand the unique experience of the person. So help me to understand. I want to understand. Did what I said resonates with you, or that doesn't resonate with you? Help me to understand.
Absolutely. Yeah, asking them to help you understand them does help them feel less alone. And that's actually what can lead on the further stage to confronting the critic. But first of all, understanding and joining.
Right, right. Yeah, and the other thing that I think it's important is to be authentic. We schema therapists, we're authentic, right? We are honest. If they say, have you had this experience, and we haven't, okay, then, just to acknowledge that we haven't, okay?
Right.
So, but we want to understand. And if we, okay, it's a kind of a risky intervention, but if we have had patients, several patients ideally, who have had similar experiences, or we have had family members or friends or acquaintances, okay, or we know by studies, papers, that some people may have a certain feeling, okay, maybe we can say it. And why? Because, as I said, some people who are acutely traumatized may have this secondary alexithymia. So just naming, okay, putting a name, in their possible experiences with certain emotions could be helpful, okay?
Mm-hmm.
So, and self-disclosure, wow, that helps. I remember a situation with a woman, unfortunately a psychologist, who had been raped. It was terrible, raped by a colleague, okay? So, okay, I will not give identifying information, but anyway, there was no possibility to sue, to take this colleague to trial. And she had been through EMDR, she had been through CBT, and there was no self-disclosure, okay, of the therapist. And it was, I'm sorry, this is very good, okay, to do EMDR, I'm trained, etc. But she was not helped. And she had all these intrusive ideas, thoughts, images, and synesthetic ones. And what helped her was that I named, okay, what she went through, and I did some self-disclosure. That was one thing that was very healing. So something like, what you went through is horrific. You were raped. Believe it or not, the naming the experience can be very healing. Maybe it's like normal for us, okay? But don't think that the persons have had that emotionally corrective experience. So thank you very much for bringing this up.
I have another question.
Well, I think that Guy was pointing out before. Yeah,
right.
So maybe Guy before and then Leanne. Is that okay? Yeah.
Okay.
Thanks.
So I would like to ask, what would be a good indication that the patient is ready for imagery scripting?
Okay.
And a rather advanced stage, from what you described.
Yeah. Well, I think we have to, and that's something I learned in the United States, to have to begin where the client is. And if the client is stabilized, yes, I think that could be a good indication to meet needs, right? Now, the patient, the person has intense anger, okay? So you try, let's suppose, Guy, that you tried behavioral techniques, okay? Behavioral and experiential techniques, like let's punch a cushion, do the rage walk as my patient did, scream, in places where, it's appropriate, do this punching ball, right? And it doesn't work. The person is still with anger, okay? So I think that some therapists who may have especially emotional inhibition as a blind spot, as an unprocessed schema, may avoid doing imagery, for instance, imagery rescripting of angry feelings. But I think that could be stabilizing, okay? And if we do, we have tried also some stabilizing techniques. So we can do stabilization through a butterfly hug, EMDR, the EMDR technique specialized for acute trauma. And but we will know, and if we make a mistake, and of course the easier one of image rescripting is meeting needs, right? So we can have somebody else, a third party helper, okay? Like I'll give you an example. You saw the image. This was a supervisee who gave me consent to show the videos, by the way. And sometimes we have to use third-party helpers, okay, because it's not appropriate for the person, to do imagery, or it's not comfortable to do imagery scripting with us getting into the image, okay? And in this case, she was naked in a shower where there was an earthquake, everything was shaking, horrible noise, and what she needed was a friend of her to go with the towel, wrap her up, help her to dress up and leave that place. So so we have to be creative, but I know you will know, okay? Schema therapists will know, and we try, different interventions first, okay? But pay attention to where the client is. I don't know if did I answer?
Absolutely. Thank you.
You're welcome.
Is it okay, Patricia? One more question from Leanne?
Yeah,
okay?
absolutely.
Thank
you. Especially if I can answer it. Not,
Hi, hello, Patricia.
Hi.
Thank you for your lecture. I would say that I don't have a lot of experience in treating acute trauma. Okay, most of my patients have complex trauma from childhood. They don't have a lot of experience with acute trauma. And I have a patient now who's a soldier, and he came to me, or his mother approached me for something else, which requires going to the childhood and to his complex trauma from childhood. But then I found out that he's just been in a very, very traumatic situation where soldiers died around him, and he treated everyone. And he just discovered that he knows how to function in those situations. And he keeps telling me that he doesn't feel anything about it. It's all fine. It doesn't haunt him. He's okay. But now I don't know. He seems fine, and I don't want to take this from him. But he approached me on something else, which requires going to childhood modes and to childhood trauma. And I don't know if it's the right time to do it. What do you advise about that?
It's a complex situation besides being complex trauma. So yeah, there could be complex trauma and have an acute trauma or an adult trauma associated to PTSD or not, an unprocessed adult trauma that is superimposed on the complex trauma. So that complicates things. And the avoidant protector, the detached protector, could be making him avoid sharing with you. Maybe the patient does not trust you, or that happens sometimes, enough to talk about that. Maybe there are some critics going on that the person may be ashamed or guilty, have survivor's guilt, for instance, that can make him, that can lead him to avoid sharing that with you. Because of course, you know, we're talking about very traumatic situations that he went through. So of course, I would not push. I would emphasize the therapeutic relationship. Okay, and you can even say, I know there are things that may be uncomfortable for you to talk about, or you may not be ready. Okay, so we're kind of planting a seed. Okay, and later on the person may share. Okay, so the question about complex, talking about childhood issues, I would not go there. No, I would not go there. Okay, because it could be too triggering. Okay, and I would go slowly, emphasize on the therapeutic relationship. Do as I was saying before, emphasize on emotional attunement, meeting emotional needs, and go slowly. Yeah.
Okay, thank you.
You're welcome. Thank you. Very, very good questions. Very interesting questions. And you, as I predicted, you have a lot of experience. And I would love that, you have more experiences, you share some experiences, the ones of you who have not shared. That would be wonderful for me. Okay, so please do.
Agara, on mute.
I'm on mute. Okay, now I'm unmuted. Okay. So I think we're coming to the end, right? And Patricia, really thank you so, so much for your expertise and your time and your generosity and your patience and your special way of doing this very, very important work that meets all of us now in different levels. Thank you.
Okay, thank you. Toda raba. Lehitraot. And shalom.
Hi, Patricia.
Thank you, Patricia.
Thank you, thank you.
Good night.
Thank you.
Thank you.
I hope you see all the hearts that people are sending you flying over the screen. Great.
Yes, that's very nice. Thank you very much.